And that's obviously a very gross
الصوت نعلي شوية لو
oversimplification,
ممكن.
but those are the fundamental basis that we base our treatment strategies on. But our knowledge has evolved beyond that. So we the concept of stress versus unstressed volumes in response to fluid boluses, to norepinephrine, has becoming more and more part of what we think about and consider on the intensive care unit. And perhaps my bias is that it's an area of interest for me. We're not just thinking about the arterial side of the circulation, but starting to think about the venous side of the circulation as well, the whole concept of venous congestion. Because we all know that actually, if you're going to perfuse an organ, the perfusion pressure is the difference between the mean arterial pressure and the venous pressure. And that's even then is a very oversimplification of the concept. So how do you go about assessing the venous circulation? Now, if you were a traditional clinician, you look at the CVP, you could look at the filling pressures of the right heart, but that would require quite advanced echocardiography skills, which may not be accessible to some of us. Equally, you could argue that echocardiography is a one-off scan at that particular time frame. A good monitor should be continuous. And so we could argue whether echocardiography is a monitor or not. But one of the things I'd like to introduce here is the concept of venous congestion assessment using point-of-care ultrasound. This is a very interesting paper published by our Canadian colleagues who use ultrasound to try and grade the severity of venous excess, the VEXAS score. This is very nicely illustrated in this diagram, and it's a stepwise approach. And the principle is that we're looking at the flows within the big venous systems. So it starts off with the IVC. Is the IVC dilated or not? And then a sequential interrogation of the hepatic vein, portal vein, and the renal vein. And the principle is that as these vessels become more and more congested, more and more overloaded, the flow within them will become more and more abnormal. And you can therefore put this into mild, moderate, or severe. So again, touching on this concept of the use of ultrasound, you can actually use ultrasound to assess the dimensions of the different vessels and in the heart chambers. You can use the ultrasound to assess for congestion in the lung, and I've just mentioned systemic venous congestion as well. So again, introducing one of my biases, which is I think that anyone who looks after a critically ill patient should be able to use the ultrasound. Along with the concept of ultrasound is the whole concept of fluid responsiveness, which is, I think, one of the slightly wrong questions that we should be asking. Because just because you are fluid responsive doesn't mean you need fluids. If I were to test for fluid responsiveness in the majority of you listening into this seminar, I suspect you would be fluid responsive, but that doesn't mean your lactate is up, that doesn't mean you're an acute kidney injury, and certainly doesn't mean you should give you fluids there and then. Because fundamentally, fluids are drugs. And I think because it's so easily prescribed, we have forgotten this very, very crucial, important fact. And like all drugs, they can cause harm. This is a wealth of literature out there that has shown that a positive fluid balance, excessive fluid, is associated with poorer outcomes, both from the morbidity perspective, but also the mortality perspective. It doesn't affect just the hemodynamics and the circulation. Too much fluid affects all the other organ systems, the hepatic system, cerebral edema, gastrointestinal system. Those of you who anesthetize or looked after patients with anastomosis, if they've been given too much fluids during the course of their operation, the anastomosis site is very edematous and they're more prone to breaking down. So again, looking ahead, we've classically divided the phases of fluid management into these four phases. So resuscitation, optimization, stabilization, and de-escalation. Our thinking, our research, and our practice tends to be focused on the giving fluid side of things, the resuscitation, optimization side of things. And I think in the same way as the RV is the poor cousin to the LV, stabilization, de-escalation in particular have been unfortunately put to the back pocket. Because when you look at these phases, you are trying to answer these four questions. When to start fluids, when to stop fluids, when to start fluid removal. Often a question that we don't ask enough, I think, and that's again a personal bias. But you can link these four phases to the concept of congestion, which I've mentioned, which is instead of asking when to start IV fluids, you can ask when congestion is absent. When to stop IV fluid administration before congestion emerges, when to start fluid removal as early as congestion emerges, when to stop fluid removal when congestion is controlled. So managing congestion is a universal priority at all times. So let's take a step back and look at the fluid responsiveness side of things. This definition of fluid responsiveness, ability of the cardiac output to increase by 10-15% following administration of a fluid bolus. We can use static markers, but more often than not, most of us have moved towards dynamic markers as the ones listed here. But again, fluid responsiveness is not the same as needing fluids. Fluid responsiveness is not the same as being fluid tolerant. And I think this is a very nice paper by Eduardo Carter and Glenn Hernandez, Philip Roller and colleagues who talk about the concept of fluid tolerance. And I highly recommend this paper. Let's have a look at a couple of ultrasound images, my area of interest and therefore bias. Look at this ventricle. It's a parasite on a short axis. It's not pumping very well. So chances are this patient is likely to be fluid intolerant. Look at this echo image here. That's a very, very dilated RV. RV systolic impairment is obvious. So again, this patient is likely to be fluid intolerant. For those of you who are doing lung ultrasound, and I think it's becoming more and more common in our practice these days, certainly colleagues who I speak to from the Middle East are very, very experts in the use of a lung ultrasound. So this is what normal lung ultrasound looks like. And these images here, as you can see, are very, very abnormal compared to the ones I've just shown you. Lots and lots of these vertical artifacts, which are B lines. And these, again, if you see this in a patient, it's unlikely for them to be fluid tolerant. If on ultrasound you see pleural effusions, they are unlikely to be fluid tolerant. They might be fluid responsive, they might be, but when you take it all as a whole, they are unlikely to be fluid tolerant. I've shown you a couple of ultrasound images. Obviously, I've picked one that illustrates the point I'm trying to make. So we can discuss this later on. But I think it's important to mention at this stage that the ultrasound is just a tool. And if you don't know what you're doing, or you align that monitor, the ultrasound, with the incorrect management strategies, you will still cause harm. So a fool with a tool is still a fool. Let's talk about the last phase of fluid management, which I introduced and mentioned earlier, this whole de-resuscitation phase. So ask yourself, do you do it? Do your colleagues do it? If you do it, when do you do it? And how do you do it? So let's look at the evidence for it then. This is a very interesting paper. So colleagues, Jonathan Silversides is based in Northern Ireland, made a survey, and he presented a couple of scenarios, very common intensive care related scenarios, to colleagues, and said, what would you do to this patient with regard to their fluid management strategies, and particularly focusing on the de-resuscitation fluid excess side of things. And I'll leave you to read this slide and the scenario, but the take-home message, and I want to highlight here, is the variability. The variability in practice amongst colleagues across intensive care when faced with a patient who they think should be decongested or offloaded. The parameters they use to trigger de-resuscitations are different. The strategies that they use to de-resuscitate patients is also different. Some use furosemide, boluses, intermittent, continuous infusion, CRRT, so on and so forth. Minimize the input, huge variation. But if you look at the literature, the evidence is again very variable. So one of the trials that are coming up, which I would hope you all would keep an eye out for, is the Radar 2 trial, again by Silversides and colleagues. And what they're trying to do is to see whether it is feasible to have a early active de-resuscitation process for these patients. And the study have just been published, keep a lookout for it, and it is feasible. Whether it changes outcome or not is a different question, but it is feasible. So we await the trials that hopefully will show or not show whether active de-resuscitation will help our patients get better outcomes. I put this in here because the Andromeda shock trial, which I'm sure you're all very familiar with, is indeed one of my most favorite ICU papers in the last decade. It's again by Glenn Hernandez and colleagues, and essentially what they did was to compare lactate-based resuscitation strategies to capillary refill time measured by a simple bedside test, no fancy chemicals, nothing like that, and it was the findings were astounding. So it raises a question whether you need fancy monitors or do you need a good clinician with good clinical bedside practice and a strategy aligned to it. Controversial? Again, we can discuss later. And this is just the findings of the Andromeda trial using the peripheral perfusion group, which is the capillary refill time. The mortality is shown there, 35%. The lactate group, 43%. Although there was no significant difference between the groups statistically speaking, the chart there provides a very interesting signal. And this is essentially just a summary of what they did. They did assess for fluid responsiveness, but as you can see, they've integrated capillary refill time as part of their management algorithm there. And this is the second half of what to do, whereas you intervene, you go back, reassess, intervene, go back and reassess, so on and so forth. And finally, let's talk about the microcirculation. When we think about the mean arterial pressure, we manage the venous pressure side of things, we're looking at the big things, the macrocirculation. So should we be looking at the microcirculation as an endpoint? Certainly colleagues such as Can thinks that the microcirculation is the bottom line when we talk about hemodynamic manipulation, hemodynamic monitors on the intensive care unit. Because ultimately all the blood substrates, oxygens, etc. are exchanged at the microcirculatory level. So can you use it as a target for resuscitation in septic shock? A nice editorial here by Matthew Legrand and colleague. And this is the sort of thing they're proposing. And indeed, if you look at all the microcirculatory resuscitation suggestion protocols, it's something to do with this. So look after the macrocirculation and then look at the microcirculation. Now, this bit here, looking after the macrocirculation, in inverted commas, is easy. Fluid therapy, vasopressors, inotropes, all the stuff that we do. But when you talk about the microcirculation, that's more difficult. So how are you going to assess and monitor the microcirculation? You could look at consensus guidelines, such as this one by the ESICM, published in 2020. But essentially, to measure the microcirculation and monitor the microcirculations are something such as this one, which is a sublingual microscope that you have to put under the patient's tongue. It's bulky, and you can get beautiful pictures such as this one, and it shows red blood cells flowing through the various capillary in the under the tongue itself. But the reporting of it is very, very complicated and variable, so the data from it needs to be cleaned up, and interpretation of what you can see can be a challenge as well. So it's there, but I think it is not quite ready for bedside normal practice quite yet. One of the things that we could look at is something such as this one. So this is contrast enhanced ultrasound, and what it involves is injecting of a intravenous agent that highlights and stays within the blood vessels, including the small ones. So you can see how different organs light up and different and how they are perfused. So this is an example of a kidney, and we've injected intravenous contrast agents, and you can see the whole kidney lights up, showing that this is a very healthy kidney. As opposed to this one, where it does light up eventually, but you would argue that it's not as bright as before, and certainly doesn't light up as quickly as before. So could this be a way of monitoring the microcirculation? Again, I don't think it's ready for bedside practice, although I know there are some colleagues in my own institution and in Jacques Duranteau's group in Paris who are looking at it. More pictures of lighting up. Look at this one here, very, very bright. And very, very quickly bright. So, some take-home messages then. I think it's fair to say on the intensive care units, we've got lots and lots of monitors, invasive and non-invasive. The monitors by itself won't improve patient outcomes. It needs to be aligned with some form of management strategy in order to trigger some action and then reaction to it. It's impossible for me to talk about all the things that we can possibly talk about on the hemodynamic monitors, but I wanted to do with this talk is to introduce concepts to perhaps guide what we should be doing, could be doing in future practices. So I've talked about fluid responsiveness, which is bread and butter what we do, but also try to introduce the concept that actually it may not be the right question to ask, and we should be focusing more on the venous congestion, the fluid access, fluid resuscitation side of things as we look towards the future of monitoring, manipulating hemodynamics. And finally, I've introduced the concept of the microcirculation. We focus a lot currently on the macrocirculation. So our SWAN, our PICO, our arterial waveform techniques are all macroscopic based. Perhaps it's the microcirculation that we need to focus our research and ultimately clinical practice on. And with that, I thank you. Those are my email addresses and contact details. There's a picture of where I work. If there's any questions or you want to reach out for collaboration and so forth, I look forward to it. Thank you very much for your time.